Hello, good morning. Today we will discuss an article review about treatment gap of mental disorders. Just I like to open the slides and then I will go to the details. The article is titled The Treatment Gap in Mental Disorder, the Treatment Gap in Mental Health Care. And it is authored by Rorebrt Kohn, Shekhar Saxena, Itzhak Levav, and Benedetto Saraceno. Rorebrt Kohn is from Brown University, Department of Psychiatry and Human Behavior, and Shekhar Saxena and Benedetto Saraceno was from World Health Organization, Department of Mental Health and Substance Dependence. And Itzhak Levav was from Ministry of Health, Jerusalem, Israel. And it is presented by me, Noor Ahmed Giyashuddin. I start the main presentation here. Introduction. Mental disorders are causing disease burden, which is complicated by being untreated despite possibility of effective treatment. There is possibility that mental disorders will get well by treatment, but the disease burden is increasing by the fact that a good number of persons with mental disorders are remaining untreated. The article measured the gap between the need of service and the service that was being fulfilled. The measure was taken from community-based epidemiological studies performed with standard procedure. Outcome measure was median rates of untreated cases of these disorders. Following disease burdens were assessed for measuring the gap in treatment. They were schizophrenia and other psychosis, major depression, dysthymia, bipolar disorder, generalized anxiety disorder, panic disorder, obsessive compulsive disorder, alcohol abuse, or dependence. Background of the review article. Mental disorders are disabling conditions unquestionably. Psychiatric and neurological conditions account for 13% of global disease burden. In 2001, it is the year nearby the publication of this article, and this disease burden is measured by years lived with disability and premature death in disability adjusted life years. Mental and brain disorders are a public health concern globally. High prevalence of these disorders cause stress or emotional toll on general public. Lifetime prevalence of mental disorders ranges between 12 to 49% according to different settings, different regions, different continents, different cultures, and different countries. 12-month prevalence of them ranges between 8 to 29% in a round figure. The load of disability is partly due to the early onset of the disorders and usual delay in getting proper mental health care. It is notable that psychiatric or mental disorders are onset in the young adult life, like in the second or third decades of life. And so when they are being untreated, remaining untreated, their load of the disorders, the prevalence of the disorders are accumulating and adding to the disease burden. Possible causes of delay of the treatment include lack of acknowledging the disease condition, believing that these symptoms constituting a disease, thinking the treatment would not be effective, relying on spontaneous recovery rather than approaching to the treatment, over emphasis on self-sufficiency, that is that the persons are unable to overcome the disease by themselves without any outside or medicinal support. Stigma about mental disorders that is prevalent all over the world to different extents. Other causes include financial issues, poor accessibility and availability of services, and to reduce this disability, we need to bridge the treatment gap. And before bridging the gap, we need to know about the what is the treatment gap and to what extent it is present. The treatment gap. We can define the treatment gap as the absolute difference between the true prevalence of a disorder and the treated proportion of individuals affected by the disorders. That is true prevalence and the difference of the treated proportion of the individuals is constituting the treatment gap. Alternatively, it may mean the percentage of individuals who require care but do not receive treatment. These two definitions try to clear the idea of the treatment gap. How can we measure the treatment gap? On which factors it depends? The treatment gap depends on the prevalence period of the disorder, whether it is the lifetime prevalence, 12-month prevalence, or 1-month prevalence. The time frame of examination of service utilization, that is when, in which season we are measuring the service utilization, or in which area, in hilly area or plain lands, in cities or in villages, etc. The demographic representativeness of the study sample with reference to the target population. The demographic or characteristics may be uniform, like in some part of Europe, but it can be ununiform or variable in case of countries like India. What was the method of the review study? Several important disorders were investigated. We have already mentioned the names. Community-based epidemiological studies with participants of 15 years of age or over were included. Studies published since 1980 or provided by the investigator or agencies after that time. Literature search was done with the term psychiatric epidemiology, prevalence, and the name of the specific disorder and the name of the standard diagnostic instrument. Book chapter and review articles on psychiatric epidemiology and service utilization were examined. Proceedings of World Psychiatric Association section on epidemiology and proceedings of American Psychiatric Association were also investigated. The studies with standardized data collection instruments generating a diagnosis linked to accepted classification systems were included. That is, there are certain criteria like the data collection instrument have to be standard. They would generate a diagnosis, and the diagnosis have to be fall into the classification, standard accepted classification system. Service utilization data were obtained from community-based epidemiological studies of psychiatric disorders. The treatment gap from each of the available studies was determined for each specific disorder. There is a footnote that is service utilization was defined as seeking assistance from any medical or professional service provider, specialized or not, public or private. Traditional healers and non-professional providers were excluded. Treatment included both somatic and psychotherapeutic treatment. The median and average rates of service utilization in the studies were calculated for each disorder. Using the median rate prevents outliers from having an undue influence. But in this study, the median rate and the mean rate is not extremely different. They lie nearby. Examples of regional treatment gap rates were calculated. Regional treatment gap calculations take into account the service utilization rate, the prevalence rate, and the population size of each of the countries. And the following was the formula used for this purpose. Now we come to the results. 37 studies had data on service utilization. The median untreated rate, or the treatment gap in this case for different diseases, are as follows: schizophrenia and other psychosis 32%, major depression 56%, dysthymia 56%, bipolar disorder 50%, panic disorder 56%, generalized anxiety disorder 57.5%, obsessive compulsive disorder 59.5%, alcohol abuse and dependence is the highest, and it is 78%. And here is the graph to show a visual expression of the height of the or amount of the treatment gap. And alcohol abuse and dependence is the highest, and schizophrenia is the least amount. The treatment gap varied among different countries to a large scale. That is, if we see the range of the treatment gap for schizophrenia and other psychosis, it is 6 to 61.5%. For major depression, it is 16 to 84%. For dysthymia, it is 14 to 78%. For bipolar disorder, 0 to 79%. For panic disorder, 7 to 72%. For generalized anxiety disorder, 33 to 74%. For obsessive compulsive disorder, 0 to 92%. Alcohol abuse and dependence, 49 to 96%. So here is the graph presentation. The upper line is the highest amount of treatment gap, and the lower line is the lowest amount of treatment gap in different countries. Regional estimates of the treatment gap were not possible in many cases due to unavailability of necessary data. For example, in Africa, only data on major depression was available, but in Americas and Eastern Americas and Europe and Western Pacific, most of the data were available. And Africa, Eastern Mediterranean, and Southeast Asia, the data were scanty and estimates of regional treatment gaps were not possible. Now we come to the discussion. The overall treatment gap would be higher if data from developing countries would be included, but they lack good quality studies, at least at the time of this publication. Common psychopharmacological agents are not uniformly available in all the countries or regions. For example, 25% of the countries do not have necessary psychotropic medications. For more than 70% of the world's population, they have less than one psychiatrist per 100,000 people. Good news is that better tolerated antidepressants have played a part in reducing the treatment gap in countries that can afford their higher cost. Failure to reduce the treatment gap influences not only years lived with disability and disability-adjusted life years, but also suicide among the patients and economic loss of the person, the family, the society, and the country as a whole. There were several limitations of the study, that the role of traditional healers and non-professionals providers were not analyzed in this review. Data related with service utilization were inadequate. Indigenous population may have been overlooked. Regional representation within a country may not be possible in included studies. The studies did not measure the adequacy of the treatment or the quality gap of the treatment. There may be some disparity between meeting diagnostic criteria and requiring medication. In some cases, a person may fulfill the diagnostic criteria, but may not require a treatment due to his good coping skill and lack of morbidity. And now we have 10 recommendations to address the treatment gap. Number 1, mental health treatment should be accessible in primary care. Number 2, psychotropic drugs need to be readily available. Number 3, care should be shifted away from institutions and towards community facilities. 4, the public should be educated about mental health. 5, families, communities, and consumers should be involved in advocacy, policy making, and forming self-help groups. 6, national mental health programs should be established. 7, the training of mental health professionals should be increased and improved. 8, links with other governmental and non-governmental institutions should be increased. 9, mental health systems should be monitored using quality indicators. 10, more support should be provided for research. And these were the directions, and what is happening, or what has happened since 2001 was a realization of these recommendations. And we have last 2 remarks from the review paper. Not only the treatment gap need to be bridged, but also the treatment lag, and which is the time from onset of a disorder and to obtaining care, need to be shortened. And finally, appropriate policies, programs, and service developments may allow the gap to be bridged for the benefit of those in need, their families and communities, and the countries and the world as a whole. Thank you for your patient listening. Thank you.